Welcome to Revitalize Education. In this video series, we are discussing vascular emergencies, specifically aortic dissections. In the following videos, we will take a closer look at the pathophysiology of aortic dissections, their clinical presentation, and assessment considerations. We also will look at how they're diagnosed and identify how to manage an acute aortic dissection. So let's jump right into the pathophysiology of the aorta and what causes an aortic dissection. Before we can discuss dissections and aneurysms, we need to understand the anatomy of the aorta. The aorta is the largest artery in the body and originates from the left ventricle. It carries blood from the left ventricle out to the rest of the body. The aorta is composed of three layers. The innermost layer is called the intima, the middle muscular layer is the media, and the outermost layer is the adventitia. In an aortic dissection, there is a tear or disruption in the innermost layer called the intima. This creates an intimal flap and allows blood to separate the intima from the medial layer. This separation creates a false lumen. As you can see in this cross-section picture, the tear allows blood to pool in that false lumen and separate the media from the intimal layer. This can compromise hemodynamics by two methods. The first is that the false lumen can compress the true lumen and limit distal blood flow. Or the second method is that the false lumen can extend into the branches of the aorta, compromising blood flow to organs that branch off of the aorta. As you can see in this picture, there are multiple branches of the aorta, all of which can be involved in a dissection. You have the coronary arteries that arise right after the aorta leaves the left ventricle, then the right innominate artery, which branches into the right subclavian and right common carotid. Then the left common carotid and the left subclavian artery arise. This section of the aorta, from the aortic root all the way through the arch to the left subclavian artery, is known as the ascending aorta. As we transition into the descending aorta, the aorta passes through the diaphragm and we see the celiac, mesenteric, and renal arteries branch off. Ultimately, the descending aorta terminates with the bifurcation of the iliac arteries. This picture demonstrates that the false lumen of the dissection can involve the branches of the aorta. These affected branches may have little to no distal blood flow, thus compromising distal organ perfusion, which in turn may cause some of the signs and symptoms you see on presentation. Oftentimes, the terms dissection and aneurysm are used interchangeably. However, these two terms have vastly different meanings and implications. As we have already discussed, a dissection is a tear in the intimal layer of the aorta, which allows blood to separate the intima from the medial layer, thus creating a false lumen. An aneurysm is a weakened area of the aortic wall, which allows for the wall to balloon out. There is a risk for an intimal tear to occur, thus converting an aneurysm to a dissection, but a true aneurysm has an intact, albeit weakened, aortic wall. Due to the ballooning of the aortic wall, these patients are also at risk for aortic rupture. Aneurysms may occur in the thorax or the abdomen, which can also be called a AAA, or abdominal aortic aneurysm. There are several ways to classify aortic dissections. The two most common systems are the DeBakey and the Stanford classification system. The DeBakey system is the lesser common classification system used. It classifies dissections based on the site of the origin of the intimal tear. Type 1 originates in the ascending aorta and extends through at least the aortic arch, but it may continue into the descending aorta. Type 2 is confined to the ascending aorta, and type 3 involves the descending aorta. A type 3 dissection may extend distally or proximally, but does not include anything proximal to the left subclavian. The Stanford classification system, also known as the Daly classification system, is more commonly used in this region. It delineates dissections based on the involvement of the aortic arch, regardless of where the origin of the intimal tear occurs. Type A dissections include the ascending aorta and may or may not include any portion of the descending aorta. Type B dissections are limited to the descending aorta. It is worth noting that type B dissections can convert to type A dissections if the lesion expands to include the ascending aortic arch. While aortic dissections are relatively rare, occurring in 4 out of every 100,000 cases, they are life-threatening emergencies when they do occur. Dissections are generally seen in 60 to 80-year-old men, and type A dissections are twice as common as type B dissections. Hypertension is the most important predisposing factor of an aortic dissection. 77% of patients with aortic dissections have a history of hypertension. Other factors that may contribute are cardiac or aortic valve surgery or connective tissue diseases, such as Marfan syndrome. Connective tissue diseases are commonly the cause of dissections in the younger population, especially in patients less than 40 years old. The weakened aortic walls seen in an aortic aneurysm also predispose a patient to a dissection. Trauma is another cause of an aortic dissection, but not in the traditional sense. Let's take a closer look. In order to better understand aortic dissections in the trauma patient, we need to review our fetal circulation. Fetal circulation is dependent on a patent ductus arteriosus, which normally closes within 72 hours after birth. When the ductus arteriosus closes, it becomes known as Harvey's ligament or Botallo's ligament. If a patient experienced chest trauma, especially with an acute deceleration event, such as with a car accident, the force can cause a localized tear, generally in the area of Harvey's ligament. This can cause a traumatic dissection or even aortic rupture. Now that we have reviewed the basics of an aortic dissection, make sure to check out our next video to learn about how these patients present.